at the Statewide Biobank is on the lands of the Gadigal people of the Eora Nation, and we pay our respects to Aboriginal elders, past, present and emerging, and recognise their many invaluable contributions to our society and their unique roles in caring for country. It is a great pleasure to be welcoming Cassandra Griffin today as our speaker. I'm sure that Cass does not need a great deal of introduction, but I will give you an introduction to her nonetheless, because she has many roles and in biobanking and in research. So Cassandra is the Biobanking and Clinical Research Manager for the New South Wales Regional Biospecimen Services based at the University of Newcastle. And she's also contributed to the growth and diversification of the Hunter Cancer Biobank and the Mark Hughes Foundation Brain Bank, with support from New South Wales Health Pathology and from the Hunter Medical Research Institute. So Cass's background is in oncology clinical trials, and she also has several years of experience in working in international medical communications. And through this, she has a keen interest in sustainability and biobanking partnerships, working collaboratively with industry and cooperative group partners to explore the role that biobanking facilities play in facilitating clinical trials locally and also in international multi-site settings. So in terms of Cass's background, educational background, she holds a Bachelor of Arts, a Bachelor of Medical Science from the University of Newcastle, and also a Master of Public Health from the University of Sydney. Hang on, I'm just getting a bit of feedback, so I might just ask people if they're not on mute to jump on mute. You know, in addition to her current working role, she's also a current PhD candidate, and her project is involved in characterising the psychosocial value of post-mortem brain biobanking from the perspective of donors and their families. And Cass is very passionate about this topic, and I think it is really a wonderful perspective that Cass's research brings to brain biobanking. So in 2020, many of you will know that Cass was elected to the role of ABNA Vice-President, and she served as the ABNA President commencing in October 2021 and just completing in 2023. And of course, many of you also know that she was one of the 2024 ISBER Meeting Program Chairs. And she also serves as the Co-Deputy Director of the Hunter Medical Research Institute Cancer Program. So we are really very grateful that Cass has taken time out of her very busy schedule to speak with us and to share her research and her wisdom. And we look forward, Cass, to your presentation. Thank you again.
Thank you so much, Jenny. It's always quite odd hearing your bio back and you think, well, geez, now people are expecting some kind of brilliance or something exciting. So I will do my best to deliver something that meets expectations. But thank you so much, Jenny, to you and to the Statewide team for the invitation to speak today. The work that we're doing here and the work that forms the bulk of my PhD is a little bit different to some of the topics that we hear about with respect to biobanking and biobanking research. But I think over the last couple of years, it's become apparent just how broad biobanking research really can be and how many peripheral disciplines and areas make up the profession of biobanking and how much work there is to be done in understanding the periphery and the ecosystem within which we biobank. So hopefully I can touch on that a little bit today from a qualitative perspective and how it relates to post-mortem brain biobanking. So just by way of context, just to explain who we are and where we are in my day job. So I'm up in Newcastle, looking after the New South Wales Biospecimen and Research Services team for the University of Newcastle. And we cover a number of different areas under quite a diverse business model, everything from solid tissue research services in TMA construction and immunohistochemistry. We house a number of external contracts and monitor multi-centre clinical trials for cooperative groups, as well as some bio startups and small pharma companies. We have our own biobanking program, so we consent patients within the local area, and we support local clinical trials. But one of the jewels in the crown of our team is the Mark Hughes Foundation Brain Bank, which is hugely valued by our community, not just because Mark and Kirralie Hughes are locals and people that are well known to many of us, but also because we're able to see the impact that the Mark Hughes Foundation Brain Bank has, not just on the local research community, but on the local community as human beings, and the feeling and the vibe that has in our region during the Beanie round and for people who are battling brain cancer is completely tangible and something that we're really, really proud of. So I think every biobanker considered it one of their proudest moments when Time magazine came forward and said that biobanking was one of 10 ideas changing the world. And, you know, these comments would not be news to any of us. But while I completely agree that biobanking is changing the world in molecular contexts and in terms of precision medicine and personalized medicine, I think what sometimes gets overlooked is the real-time and sometimes instantaneous impact that biobanking has on our donors and on us as people, not just us as scientists. And that's something that I'm hoping we can reflect on a little bit today. Brain biobanking is a unique field of biobanking, and that's because it has complex ethical, biomedical, logistical, and psychosocial factors. We deal with tissues and materials of all forms as biobankers, both human, animal, mineral, vegetable, but the brain really is unique in the meaning that we give to it and the way in which we need to talk about it. Because of that, it has huge possibilities in terms of medical advancement and what it can be used for behavioural studies, psychological disorders, ageing, neurodegenerative diseases, infections, and neuro-oncology. But we need to apply special considerations when biobanking brain tissue to make sure we're able to realise all of these potentials and gain the most out of these donations. As a little bit of an overview and just to kind of add some context to what I'm going to be speaking about today, I just want to give you a whistle-stop tour to the history of brain banking, because personally, and maybe this is me just nerding out, but I think it's actually a really interesting topic. Brain biobanking spans a history of around about 400 years, though I'm sure if we went deeper, we'd find even more going further back. But the first officially known biobank was curated by an artist. And for anybody who has been past Dangerfield or any of those kind of steampunk kind of brands, you'll see often patterns of skulls and roses and that kind of morbid but yet artistic movement. That's the Vanitas artistic movement. And it began with a brain bank, with people sketching and creating real life inspired artworks involving brain and skull kind of imagery. From there, we had the black market economy, and this was in response to some of the private anatomy schools that were set up in the early 1700s. But cadavers were particularly difficult to come by at the time, and particularly with the role of the church, it was difficult to harvest brain tissue without it being seen as sacrosanct or something that was incredibly frowned upon. This was changed in the late 1700s under the English Murder Act, which deemed that anybody who was convicted of murder, in addition to being sentenced to death, part of their sentence included the donation of their brain. These people were considered as being morally corrupt, and while the brain was recognised as the seat of the soul, these individuals weren't seen as being compromised because their souls were already compromised from the sins that they had committed, and therefore the church could agree to a degree that these samples could be donated to anatomy schools. It was a legal provision of biospecimens for the first time. That said, the church did still have some quandaries over this and couldn't completely be on board with the donation of samples, particularly when it wasn't always an open shut case and when there was outcry over certain sentences that were passed down. But with the French Revolution in 1799, we had the separation of church and state, and hospitals were no longer under the jurisdiction of the church. And we saw the institution of the first scientific brain banks, which led to a golden era of pathological diagnoses. And some of our greatest advancements were made during that time when we finally had free access to human brain tissue. Unfortunately, history has ups and downs, and one of the greatest periods of advancement in the characterization of pathological neurological disorders was during the rise of the Nazi Party. And in many ways, that was due to this man here, Julius Halberder, and I'm probably mispronouncing that. But Julius was a member of one of the hospitals involved in the T4 euthanasia program, and he collected over 10,000 samples during the extermination program. He was notorious for going in and inspecting people while they were still living, and he handpicked his victims prior to euthanasia. He felt that to not collect the brain tissue would be a waste, and collated one of the largest collections of brain tissue in history. As I say, it did lead to over 30 medical eponyms and disorders being identified through this collection, but obviously as a massive, unconscionable atrocity that flies in the face of everything we hold dear as researchers with respect to ethics, morality, and informed consent. As a way of making amends for this, under the Declaration of Helsinki and following numerous inquests into the work of his collection, many of these slides were actually interred in 1990 and buried under a memorial. No one debates the value of these slides, but it was just seen that they basically could not be kept under good conscience and they could not be used in further medical research. And as I say, they're being left in this memorial now to try and atone for what was done in the past. Something that I have always found interesting, though, karma does have a way of working out. After he himself passed away, he was committed to an anatomy school as a specimen and is still being used in a de-identified manner, of course, but has become a medical experiment himself, which there's a little bit of poetic justice, I think, in some ways. But modern biobanks are completely different, and we have turned our back on, well, not turned our back, but we have overcome what has been done in the past, and we now have strict moral and ethical regimens that ensure that anybody we work with is consented under a stringent medical consent framework. As a bit of an introduction to brain cancer, the work that we do is solely in brain cancer, and I'm conscious that a number of people who are dialing in today have probably been in brain banking far longer than I have, and that there is a huge culture of brain banking and some amazing work that has been done throughout our country in brain banking. So I possibly will be speaking a little bit out of turn considering the expertise online today. But we are one of the only brain cancer exclusive biobanks. We're not the only one, but we are one of them. So to give context to the work that we do, 2/3 of adults who are diagnosed with glioblastoma survive less than 2 years post-diagnosis. The incidence is increasing rapidly, and in Australia, it's the 6th most common adult cancer. Unfortunately, we still have an incomplete understanding of brain tumour biology. There's very little we know about its pathogenesis, and our chair of brain cancer here at the university often says that GBM is likely 10 or more diagnoses rolled into one. The interventions that we have are suboptimal in their efficacy and their tolerability, particularly when we look at the most aggressive of cancers. And there's a broad consensus in the literature that we aren't going to be able to improve outcomes for patients, which have not improved in 30 years, until we improve our understanding of the neurobiology of brain tumours. And how do we do that? Well, it would come as no surprise to everybody on this call that biobanks are a key aspect of that. Brain cancer biobanks can collect a multitude of specimens. For us, we have surgical tissues, both formalin fixed and fresh, blood, which are sequential samples collected right from the point of pre-diagnosis, pre-op, right through until the person passes away. We try and keep going as long as we can and as long as it is practical and appropriate to collect from these patients. We've recently stopped our CSF collection because we didn't have high demand for these samples and because there doesn't seem to be at the moment an agreed protocol for collection and storage of CSF for brain cancer specimens. There's a lot of work that's been done in neurodegenerative and other disease spaces. But while there's a little bit of discussion going on about that, we've temporarily paused. And if anybody on the call would like to chat further about that, I'd love to discuss. But we do collect post-mortem tissues, and we obviously collect extensive outcome data for these patients. A little bit of a background to the Mark Hughes Foundation Bank. So for anybody who's not familiar with Mark is an NRL player who played for the Newcastle Knights, and he was diagnosed with a grade 3 oligoastrocytoma in 2013. He and his wife, Kiralee, started the Mark Hughes Foundation shortly after, and one of their first acts was to set up the biobank here at the university. It started with the sequential collection of blood samples. We were already collecting FFPE samples at that stage under the Hunter Cancer Biobank, but we were able to enrich our collection when pairing it with sequential blood samples. And below there, you can see a snapshot of what we currently have in our bank. We are huge proponents of avoiding biohoarding, and we make sure that the samples that we store do go out. In 1 year, we were able to proudly say that 30% of the aliquots that were produced were distributed in the same year. So we work really hard to make sure that we turn our samples around as quickly as possible and that they're sent out to researchers as their donors have intended. We also collect MRI and imaging data. We're in a bit of a state of flux at the moment as to the best way to store this and to ensure that it's all easily accessible, but we are making headway with new databases. 2 years after we established the MHF Biobank, one of our participants who had been a long-term donor to the sequential blood donation program into the terminal phase of her disease. She was an absolutely incredible woman. Her name was Jackie, and her family are always adamant that they want me to share her name because this is her legacy. She was a foster mother who had had huge numbers of children come through her home over the years and had a massive heart, somebody who was driven in all ways through life by altruism. It was the heart of everything she did. And she approached us and said that while she knew nothing further could be done for her condition, she wanted to donate her brain to brain cancer research. It was just the logical thing for her to do. This wasn't something that we had done before, and when we looked around at other programs that were nearby, there were a number of post-mortem brain donation programs, but at that stage, nobody exclusively working with brain cancer tissue. So we hit the books to try and work out whether or not, A, this was worthwhile doing. We assumed it would be, but we wanted to know for certain, and how best we could do that. And when we looked through, these were some of the sort of key concepts that we took away and some of the key arguments that we used when making a case for expedited ethical approval. When we look at surgical samples that are the primary samples used for brain cancer research, the three objectives to removing brain cancer tissue is to obtain diagnostic material, alleviate the existing deficit caused by the mass, but also to ensure that surgery is conservative enough that it doesn't introduce new functional deficits to the patient. And in doing that, it means that quite often we have a suboptimal insight into temporal heterogeneity. We are only looking at one time point. We miss spatial or topographic heterogeneity in that biopsies in particular or specific resections don't allow us to look at the peritumoral zone or the areas outside the specific foci of tumour. And in doing so, we also don't have access to the tumour microenvironment, which the literature is showing us is increasingly relevant in understanding brain cancer. To dive into that a little bit further, we know that heterogeneity is a hallmark of glioblastoma. Spatial heterogeneity and understanding spatial heterogeneity will allow us to look at the more phenotypically diverse populations of cells to understand more about the mutational benefit, different histological subtypes, and again, to look at the peritumoral zone, which is where 90% of recurrences occur. In terms of temporal heterogeneity, secondary debulking surgeries can be as low as 10 to 30%, which means that we're not able to look at histological examples of treatment effect, of resistance and hypermutational phenotypes, the selection or aggression of tumour cell populations, and more importantly, disease progression. We know that these cells overcome our limited arsenal of therapies, but we don't know why. And being able to look at tissue that has been exposed to these therapies may allow us to gain a greater understanding. The elephant in the room with any kind of brain cancer biobanking is post-mortem interval. And there are some really conflicting papers out there. Some say that post-mortem interval is somewhat negligible and not something that we need to consider, given the advancement of the technologies that we use to work on these tissues. Others say that it's absolutely paramount to achieving a high-quality sample. This is a review paper that we put together a couple of years ago, looking at the various molecules that could be attained from these samples and whether or not post-mortem interval had an impact. And overall, what the literature seems to suggest is that for brain tissue in general, not necessarily brain cancer, post-mortem interval can be negligible, and that pH is perhaps a better indicator of quality. We're not completely sure why that is, and it certainly is in no way comprehensive, and there's no straight answer. Effectively, it is something that is being debated and will continue to be debated for quite a long time, but it does look as though there is a degree of wiggle room with respect to post-mortem interval, and papers that have previously suggested PMI must be limited to 1 or 2 hours, else tissue is useless, may not be correct. Obviously, the fastest the better. I remember an old neuroscience lecturer once saying to me, time is brain, and that's the adage that we favour in our program. It's even more important for us because glioblastoma does differ largely to many of the brain samples that are banked worldwide. And much of what we know about post-mortem interval and pH and how to preserve these samples comes from models of neurodegenerative disease or healthy controls. I won't go through all of this because this wasn't sort of what I wanted to focus on today, but as you can see, the phenotype and the context around brain cancer banking differs greatly when compared to neurodegenerative disease. Increased brain mass versus decreased brain mass, necrosis versus apoptosis, long-term agonal phases which increase hypoxia and also hyperpyrexia in terms of malignant fever and paraneoplastic syndromes. So because of that, we have aimed for a 4-hour rapid autopsy program. We don't always reach 4 hours. And for patients who are longer distances away, and I'll speak to this in a little bit, we do extend to 12 hours. We would never say no to a patient. If we hit 13 hours or 14 hours, there's no way that we would call off a brain donation. And I think the reasons why will become a little bit clearer when I move into some of our psychosocial data. But in a perfect world, we aim for 4 hours or less with our donation program. That starts with an extensive consent process that involves the next of kin quite closely. Unlike with some other disorders, we're able to see these patients coming. We're not waiting for a coroner's report. We're not waiting for a list from a mortuary. We consent these patients and we work with them as early as possible. And in some cases, these conversations are taking place quite close to diagnosis because people want to put these arrangements in place and then forget about them. We make sure that next of kin are on board from the start due to the requirement within New South Wales for next of kin to provide enduring consent after a person has passed away. So we complete the legal documents in that first consent visit, but once a person has passed away, despite them signing the consent form and then signing a consent to non-coronial autopsy and the next of kin signing that, next of kin do have the opportunity to change their mind and decline the donation at the time. So we work with them quite closely, and to date that has not happened. We've never had a next of kin say no. We ensure that our consent process is incredibly extensive, and a number of our donors have actually come and toured the facility. They've seen the lab, they've met our researchers. Obviously, we have to be incredibly careful that all of our samples are completely identified and that we preserve confidentiality. So it's done in a very careful manner, but we have found that multiple families have wanted to come in prior to donation just to meet the team and see how things work. When someone passes away, we have a 24-hour on-call biobank phone that's always manned by one of our team 365 days of the year and has been for the last 6 years. Once the patient is certified as deceased, we can then remove them from the place that they have passed in here to the John Hunter mortuary. That's probably the largest challenge that we face. At least half of our patients pass away in the home. And that means that we need a community doctor to be on call 24 hours a day to come out and certify them. In New South Wales, we can have an ambulance called or a registered nurse complete a validation of death. A validation of death means that we can legally move the patient from their place of death, but it's not sufficient for us to carry out an autopsy. We do need a full death certificate. So where possible, we try to have a GP attend the home to complete the paperwork all in one hit. We then go through the enduring consent process with a designated officer, transport the patient here, collect the samples, and then we're in touch with the family in the days to hours afterwards to ensure that the patient is then transported to whatever funeral home for whatever arrangements they've made. In terms of our banking protocol, sorry, the slide's slightly out of date. We're currently on pause, as I said, with our collection of CSF, but we remove the brain as a whole and undertake a gross dissection. We have photographic documentation of the macroscopic section, and then our pathologist will work through and select representative coronal slices. We don't store the whole brain in most cases. We do store representative slices, and we pair them as fresh frozen samples that are snap frozen in liquid nitrogen with FFPE. And the reason for this is that we're then able to carry out a H&E on the FFPE samples to work out what is within reason within the adjacent sample that has been fresh frozen. We then have a full pathological report, which is based on the H&E slides, and all of our samples are catalogued into open specimen. The tissue that isn't stored is then returned to the donor for burial or cremation. Donations do typically happen between 2 and 4 a.m. which is highly problematic. And as I said, the frequency of home death is around about 50% for us. Made even more challenging is that we cover a massive geographical area in the Hunter New England district. And we have patients passing away on extremely remote properties and in some quite difficult to get to areas. This can be challenging, and because of that, we work really closely with local healthcare teams, and we do things the country way. It's not always something that has an established process, but we build relationships and we set up informal systems to allow us to make sure that we honour these patients' wishes. And to do that, we rely on a lot of altruism and goodwill from the local healthcare teams. We actually published a paper on this a couple of years ago, looking at the informal systems reform that we carry out in regional areas, showing that with communication, innovation, contingency planning, and relationship building, you can implement very, very high quality, stringent research protocols into incredibly resource poor communities based on the goodwill that you can engender by partnering to achieve the wishes of the patient. And we were really proud that we were able to do that, particularly for this patient that was referenced in this scenario, who lived 5 hours drive away from the brain bank on a regional property. But what I was hoping to speak about today is slightly different to the nuts and bolts of our usual biobanking program, and this is about the patient behind the biobanking program and why we do what we do and the impact that we see it having on those patients. So I hope that I've been able to show that biobanking brain tissue from brain cancer patients does have extensive biomedical and scientific value. What we don't know, though, is the role that biobanking plays in the psychosocial well-being of donors and whether or not this could be taken a step further and employed potentially as a palliative intervention. I've spoken about, the statistics around brain cancer, but when you really stop and look at what brain cancer does to a person, it's absolutely horrific. It's insidious. It comes out of nowhere. It strikes people down when they're in their prime, often under 40 or having just retired and getting ready to travel and spend time with their grandchildren. And it takes everything from them, their speech, their motor skills. It creates personality changes, severe fatigue and headaches. These people can't drive. They can't interact with their social networks the same way. And they experience extreme social isolation, despair, and anxiety, as do their carers, who have a huge burden of care in trying to look after these people who mean the world to them. And overall survival is around about 13 months. We really don't have much in our arsenal to be able to treat these patients and to provide hope. So there is a dire need for something that provides hope, empowerment, a sense of meaning, and can restore some sort of control for these patients. They are being told no in every way. No, you can't drive. No, you can't see, you can't walk, you can't hold a pen. We're the people who get to say yes, and we're the people who get to give a degree of control back to these patients. And that's something that we take really, really seriously. This idea came from a jar of Nutella, and I apologise for anyone who's heard me tell this story before, but this is really where it all started. I was called up to Newcastle Private Hospital to meet with a patient who was the mum of 2 young kids, both under 14. And when I walked into the hospital room, she was sitting up, smiling, eating a jar of Nutella with a spoon. And we went through the consent visit. Her family were absolutely beautiful. She signed all of the paperwork, and I didn't hear from her for quite a while, until several months later when her husband rang. She had passed away, and he was driving home to tell his daughters that they had lost their mum. And he rang me and said that he had been sitting outside the operating theatre for every one of her surgeries, but due to the timeliness and the need to tell his daughters, he wouldn't be able to physically be present for the donation. And he felt a sense of loss at not being able to support her through this. And he asked me to attend her autopsy and be part of the process. Typically, I don't attend autopsies because I work very closely with these patients and their families, and I develop quite strong relationships in many cases. And as a form of self-care, I guess I've had to draw a line between working with the tissue and working with the patients. And I'm very fortunate that I have a wonderful team here who are able to share those roles and step in when I step out. But at being asked to do so, I acknowledged his wishes and I did attend the autopsy. And his words were going around in my head as I was watching the process and assisting with the retrieval of tissue, that all of this would have been such a waste if I couldn't make something good from it, and that he wanted to know she was at peace without the tumour. And as I was trying to reconcile the scientific process that was taking place in front of me with all of the humanity that I had experienced in getting to know and connect with this family, we sort of made the decision that we needed to look into this and we needed to measure it to truly understand the humanity behind brain banking. So I went back to school, and yes, that's my puppy dog, who is gorgeous and keeps me sane during some pretty tough days with some of these beautiful families. The first thing we looked at was, what does the literature say? Is there anything in the literature that will allow us to understand how people feel about post-mortem brain banking? And then looking at our specific brain cancer community, what does our community say about what this program means to them? In terms of the literature, there's not a huge precedent, but we did look at the transplantation literature. That said, it's not easily exchangeable, and there are massive differences between regenerative organ donation and brain donation. And again, I won't go through all of this, but while you can see an immediate impact from regenerative organ donation, for brain donation, we know that research is a long game. So it's more difficult to show benefit to patients and families in these modes. There's also the idea of brain exceptionalism, which I'll go into a little bit later. Some people would suggest that it's easier to donate lungs, a liver, or kidneys, as these are just mechanical parts of us. But a brain is who we are. It's where our memories are, our thoughts are, our deepest secrets. And the literature has suggested in some senses that it's harder for people to come to the idea of donating brain because it's donating who they are and a part of who they are. But what was concordant between our experience and the transplantation literature was that donating an organ after somebody had passed away provides a practical focus for next of kin, and that it could restore control and give meaning. And anecdotally, we'd already seen that within our population. So we looked a little bit more deeply into this, and we found that for next of kin who participate in end-of-life decisions, there's often an ability to overcome those feelings of helplessness and powerlessness to make meaning from selfless tragedy. And that it can provide almost a sense of distraction or focus and comfort in these modes. And 98% of people were satisfied with their decision. People weren't demonstrating in the literature, and some of this was actually Australian literature conducted by some of our colleagues, that people weren't upset. Well, they were upset by the request at the time, but when they looked back, they didn't demonstrate regret that they had consented to somebody donating their brain. So if we can look at that and say that, broadly speaking, consent to donating someone's brain doesn't lead to an exacerbation of grief or regret, could it potentially have a positive impact on grief? And we then also wanted to know, does this have any impact on donors themselves? As I mentioned, there are psychosocial challenges to donating brain, the idea of brain exceptionalism. There was the idea that certain religious groups may have obligations, or they may feel that religious doctrine is opposed to that, although the data has actually shown us that in many cases that is a misconception, and there are very few, if any, religions that would prohibit something like this. They tend to favour altruism in their teachings. And also, as I mentioned, there are historical challenges, and this applies to all levels of biobanking in terms of the trust and the mistrust that has been, I guess, instilled through some of the atrocities of the past that we are still working to overcome in our community. So in order to do this, this little biomed undertook a qualitative study, which was completely new to me and not something I had ever touched before. But we set up semi-structured interviews, and these were employed with two cohorts, a retrospective cohort of participants who were listed as next of kin from donors who had already passed away and donated to the MH Biobank. And we also prospectively consented people who were going through the consent process at the time. And sorry, I just realised I put those around the wrong way. So sorry, just ignore that there. But yeah, so we were consenting people who had already been through the process, and then consenting people who were preparing to go through the process. The interviews were largely conducted in person, though when COVID hit, we did have some interviews taking place via Zoom and over the phone. Qualitative research is a little bit different. The rule book is a little bit loose in some ways, and we tried to make this a very participant-driven approach, whereby they were semi-structured interviews. We allowed participants to to walk through their narrative and to really tell their story, and we guided them based on what we had. We looked at their reflections on the logistical challenges and the considerations that had come to mind for them, their hopes for future outcomes. But really what we were focusing on was their experience of grief and mourning, both anticipatory grief in the lead up to their loved one passing and their reflective grief, looking back at their mourning period. We transcribed the interviews and they were coded using the in vivo software, and we carried out what's called a reflexive thematic analysis with narrative synthesis, which is where we worked through all of the data. We coded it based on patterns of language, recurring phrasing, ideas that were reappearing throughout the text. And then using frequency analyses of how these ideas and themes are being raised, we were able to develop wider themes to make sense of the data that we had. And I appreciate I'm doing a horrific job at explaining qualitative research, but it's taken me several years to wrap my head around it, and not something that's easy to summarize. But we listened, we tried to provide meaning to what was being said to us by our participants, and then we tried to put that into a logical framework. We had 40 hours of interviews with 45 next of kin that allowed us to do that. We also have 20 donors who have been through the interview process, but I don't yet have the data from that, so I won't be speaking to that today. A paper that we have just recently had published looked at the cohort that we consented and spoke to prior to donation. And I won't go into this too much because that data is now freely available if anybody is interested. But some of the key points that came out for me was that next of kin felt that going through a donation process and speaking about donation and understanding that they could play a role in medical research provided them with another avenue for advocacy and a source of community. And in a disease that is somewhat under-recognised and not always spoken about in the way that something like breast or prostate cancer may be, they felt that this empowered them and gave them a reason to go out and speak within their communities and their wider circles about the need for greater work to be done in brain cancer. It also provided them with a practical focus, and carers are inherently practical, goal-driven people who are trying to find something tangible to support their person who is disappearing in front of them, and to be able to do something practical to help them and support them and honour their wishes in that moment was of huge value to carers. It also allowed them to start and think about what their role would look like after their loved one has passed away, which is something the literature tells us is incredibly difficult for carers. For me, something that I found particularly interesting and something that I think is probably one of the greatest contributions of this work is that it allows next of kin to have end-of-life conversations earlier, where quite often they won't want to speak about, where they might pass away, whether there could be hospice care involved, arrangements for burial, things like that. Talking about something positive, like donating to a research cause, brings with it the opportunity to talk about end-of-life decisions. And many of our next of kin expressed that they were grateful for the opportunity to raise the conversation much earlier while people were lucid and coherent, and to get all of that planning out of the way. It gave them a degree of comfort and peace of mind. The paper that's currently under review is looking at our retrospective cohort, the 23 people, I think it is, who are looking back at what it was like to go through a brain donation process and to support their loved one. And there were 4 key themes that came out of that. The first thing that was really apparent to us was that the decision to support someone to donate their brain is not a drawn-out decision. Supporting their donor's agency is something that is really important to next of kin. And that makes sense intuitively when we consider that these people have had so much of their agency and their independence stripped away from them by the disease. It's considered a logical choice, and there's a prevailing reference to altruism between donors and next of kin. Some of the quotes that I've got there, and again, I won't go through all of this, but please feel free to contact me or to have a look at the recording if you'd like to go into it. But, a next of kin has said it wasn't our decision, it was his decision alone. And it was the one thing that he wanted to do, to contribute in some way and leave some sort of legacy, whether it's helping someone or finding a way to treat or cure or to improve the quality of life for someone in the same situation. It wasn't much of a discussion. He said, this is what I want to happen. And we went, yes, no problem. The other thing that came out was that next of kin didn't feel as helpless because they had something practical that they could do for their loved one. And they found that supporting someone to donate to a brain bank was a source of comfort, pride, and empowerment. So they saw that his reason for the path that he's been on is to try and help other people. And my reason for being on the path with him is to make sure that this donation happened. They felt that they possibly couldn't have coped with the overwhelming grief if they didn't have a goal and something positive to work towards, that without it, it would have just been a blackness and a void. And I thought this was really interesting. This was from a father of a daughter who was passing away. And he said, we talk about it, about how you're finding the small little bit of light in this crap, that without that, where would they be? And he said he would have gone bush. He would not have wanted to continue on living the life that he was living. But knowing something positive could come from this, and knowing that one day her donation might lead to something, gave him a reason to push on through the grief. The other thing that came out was the idea of purpose and meaning making. And as I said, this disease hits people in the prime of their life, and it can be so difficult for both people diagnosed with the disorder and their loved ones to find meaning in the tragedy that has just come out of nowhere. But they see that because they've donated, they feel that it's not completely in vain, that it would have been more distressing not to donate because there would have been no reason for what they'd been through, that it would have just been burned with her with no possibility of anything positive coming from it. And I thought this last quote was particularly beautiful. This was from the daughter of a mother who had passed away. And she said, I hope that others get a chance, if they're losing a loved one, to lose someone with disgrace. The dignity that it gave her and to me is something they can't thank anyone enough for. And that was really beautiful to hear, that it had meant so much to them. There was some constructive work that came out of this paper. And we did look at perceptions of the processes and the procedures to see if there was anything that we could improve on. One thing that came out of it was that the rapid timeline can sometimes cause distress. So we're extremely conscious now that while we are open about the 4-hour timeline, we ensure that next of kin don't feel pressured, and that if they need more time, they know they are not compromising the process by taking that time. We've certainly never rushed anybody, or that we're aware of, but we understand now that just in expressing early on that this is our goal, people want to do this and they want to do it well. So it's reiterating to them that they can take the time that they need and things won't be compromised. Probably the biggest thing that came out in terms of areas of distress was the idea of the body bag. People found that as something that was quite confronting, and we now warn next of kin who have someone pass away in their home that in seeing their loved one placed into a body bag and the body bag removed from the room, it may cause them distress. And we try to forewarn them so that they can give thought to whether or not they would like to be physically present during this process. On the flip side, we did actually have one person say to them that it became easier once their father was placed into a body bag because it was no longer him. So, it is highly coloured data in that the range of variability within it is huge. But overall, people have said that they didn't find it a difficult process. It was an easy process compared to everything else that they've been through, and they felt that they had sufficient support. Our next steps from here are the donor interviews, and we're hoping to start on these in the next week or so. And after that, we have a survey that's going out nationwide to palliative care and oncology professionals, looking at their perspectives of brain donation in brain cancer settings. What our systematic review showed us was that there were only 2 papers that had included the perspectives of healthcare providers, and they only looked at barriers. So it would be really nice to understand whether or not they see the value or how they characterise the value of these protocols. And from there, we'll then work on reviewing and amending our operating protocols. Just very quickly, because I appreciate we're getting quite tight on time, but if anybody is interested, we had an incredible experience with one of our donors who demonstrated terminal lucidity. She had been deemed completely completely unresponsive for a number of weeks. She had lost fine motor skill, and we were told that we would not be able to get consent from her to carry out a brain donation process. Her family persisted because there was written evidence in text messages and emails between each other that this was something that she really wanted, and we put through an exception to our ethics committee for a waiver of consent. under the understanding that her next of kin had enduring guardianship. We managed to get approval for that, and when I arrived at the hospice to get her family's signatures, she was actually awake and lucid and had the fine motor skills to hold a pen and complete the paperwork in front of her, which was something that her care team really couldn't explain. So if you'd like to know more about that, it's an experience that stuck with all of us. By all means, feel free to have a look and have a read. Our first donor passed away on the 14th of February in 2017 at the age of 62. And since then, 36 people have donated to our brain bank, with 9 who are currently consented. That is incredibly humbling to us that so many families have trusted us with this gift. And we really do hope that the data does speak for them and that they feel that what they have done has made a difference, has given them meaning, and has supported them throughout what is a horrific, unspeakable tragedy. It's not just me running this program. There are a huge number of people that have contributed to this work, to the brain bank, and to the infrastructure around the brain bank that keep us going. I have an incredible supervisory team for my PhD. Professor Marjorie Walker was a huge part of that, and unfortunately she left us a month ago to an equally insidious and understudied cancer. And I think it was just a reminder to all of us that these diseases don't discriminate. They can come for anybody, and that the work we're doing does matter as biobankers. It impacts donors and researchers in real time. It provides them with the resources that we need, but it also means the world to our patient community to be able to fight back and to contribute and to play their part collaborating with research. And I hope that in exploring that and walking through some of that, as biobankers, it gives everybody a little bit of pride that we're not just helping research, but we're actually really supporting and helping the community and adding meaning to their journeys. And I'll leave it there and see if anybody has any questions.
Thank you, Cass. That was a wonderful talk, very moving. And I think, as you say, a great example of the value of biobanking, not only to research, but also to participants and donors. So thank you for that. I'm just going to look for some questions. I think we've got one. Oh, yes, we've got another comment. Great talk, Cass. Thank you. Look, while we're waiting, people could just either pop your hands up and I'll call on you, or if you can't speak because of where you are, you're very welcome to write something into the chat and I'll read that out on your behalf. So just while we're waiting, look, I do have a couple of questions. I mean, one was around the CSF collection. You mentioned that you've paused that, and I'm sure you're probably part of these discussions, but I was at a meeting convened by BCBA, Brain Cancer Biobanking Australia. Marion Mattias was talking about protocols and for collection of CSF. I'm just checking whether you're part of those discussions.
I hadn't been, and I would love to be, because there was actually a BCBA email that went around asking for anybody collecting CSF to share.
All right, I'm going to put you in touch with Marion.
I would love to. Thank you.
Yes, that's all right. I know that the Children's Hospital at Westmead Biobank had been collecting CSF from brain cancer patients for many years, and interestingly, you know, there hadn't been a lot of demand for it, but the Children's Hospital at Westmead also has a collection of CSF samples as well. So maybe it's a case of a sample coming into its own, you know.
Absolutely. And I mean, I guess that's something that, you know, as biobankers, we're always kind of juggling the idea of collecting for future use versus something that's in demand now. I mean, I have some amazing colleagues who provided protocols and opinions on the best way to go forward. It was, as I say, there didn't seem to be a consensus, which we thought we'd just pause for the moment. I mean, these donations don't come through every week as well. So we thought we had a little bit of grace time to be able to make sure what we were doing was right. But I would love to be involved in those conversations, because if we can make this a robust protocol, we'd absolutely start collecting again.
Great. I'll put you in touch. And I guess I had another kind of question around, I mean, I certainly really like you know, the narratives of having something practical to do in the aftermath of someone passing, I think resonates probably with a lot of people. And I'm just wondering whether, you know, an example of, you could almost argue that, you know, the organising funerals and things like that not only are about commemorating a person, but they also give the family something immediate to focus on afterwards. And I'm wondering whether there's any literature on other kind of, post-passing rituals like funeral organisation and things like that, whether there's evidence that people find those activities useful as well.
Absolutely. And that's something we've actually discussed in the paper that's under review at the moment, is there's pushing me here to try and remember exactly what was in there, but there are 4 pillars effectively of creating meaning after somebody has passed away. And part of that is in celebrating and remembering achievements. And I guess in most cases, we would see that taking place in the form of a eulogy. But what we're finding with our patients, and actually we had one interview where she said that she didn't really feel it was a legacy. She didn't really feel that he had done anything great in donating his brain. But when we drilled down a little bit more, she spoke about his obituary. And she said, I still feel guilty that I forgot to put his brain donation in his obituary. I mentioned all of his other achievements. I mentioned his awards. I mentioned his accolades. So while she couldn't necessarily make the leap to calling it a legacy, she definitely saw that it was something that should be celebrated in the aftermath of a passing and something that was part of making meaning for his life. And legacy seems to be something that is hugely important to our donors, feeling that they've left something behind. And again, I think that also ties into brain exceptionalism, which we look at as being something negative. People don't want to leave themselves behind. The flip side of that is I have had so many people say, oh, I guess I get to come to work with you each day, or, oh, you send samples overseas. I guess I might see a little more of Europe than I had already. So it can definitely be looked at through a multitude of lenses. And I think that's why I personally find it such a rich and interesting area. It's just so human.
Yes, that's right. Does anyone have any questions for Cass? We've got a bit of time. So, yeah, feel free to put up your hand or pop something. Oh, yep, we've got one in the chat. Hang on, yep, we've got a couple. Okay, so have you seen an increase in interest from participants or researchers since the current Australian of the Year? Of course, Professor Richard Scollier has been very public about his own journey with GBM since mid last year. No, that's a great question. Thank you, Candice.
Yeah, absolutely. Look, I think what Richard is doing in terms of his novel treatment protocol has certainly created a lot of talk in the brain cancer community, and it's something that patients are incredibly aware of. I wouldn't necessarily say that his work is having an impact on our interest in brain donation, because obviously what he's doing and the hope that his instills that people might not get to the brain donation stage. So I think I wouldn't necessarily attribute anything there, but I will say that we always know around about the time of the Mark Hughes NRL round, we have an influx of patients contacting us after that. So while I would say that Richard Scollier is inspiring hope of a different kind, certainly it's increasing the conversations around brain cancer. And up to sort of 5-10 years ago, I would suggest that I personally wasn't hearing about brain cancer in the media or just in normal social discourse. So he absolutely could be contributing, but I hope that he's contributing to hope of a different kind.
That's a great answer, I think. We've got a question from Anusha just about logistics, and given distances involved in a regional area, what would be your ideal solution if money was no object?
Oh, could we have our own plane? We'd have our own plane and our own doctor, and we'd flying doctor our way around to do that. Yeah, look, any biobanker with an infinite budget, what couldn't we do? We can look what we do without a budget. I would love to see us have a physician on team, because that is something that creates a degree of angst, and I do my best not to allow donors and their families to see my concern around whether or not we can get someone into the home. And yes, I see that you're not offering to make it happen. But yeah, it definitely, I would say that that's one of the largest causes of distress, and one of the most difficult things I have to manage is when someone calls me at 3 a.m. and the GP is not answering the phone. And you know, I've had relatives say to me, look, I'm just going to put them in the car. I'll say they died on the way. And, you know, you have to sort of talk people off the ledge and say, no, we can't do that. You end up with 2 laptops and 3 phones in your pajamas trying to work out a contingency. But we do have plans A through to Z when these patients pass away. And I think that's an important part of our role is for them to understand that all they have to do is make that phone call to us. After that, everything is on us, and we will always make this happen. We will always find a way, and we won't let them down. But I would love to eliminate that altogether and say, here's our person on the payroll. I'll have them out to you in an hour. That would be the dream.
Right. Well, that's good to know. Maybe some people with deep pockets will listen to this talk and take note. I just have a really quick final question. I think you talked about, some of your patients being adults, some being children, but what about that middle ground of adolescence when, patients are developing agency, and certainly in the paediatric setting, patients can assert assent from a particular age. Have you had any patients that have fallen into that adolescent category?
So we don't actually...
without giving any, details away.
We don't actually collect brain tissue from adolescents. We are only an adult program. We do have a partner program here who do work with DIPG and paediatric tumours. So it's not something that we have faced. However, we do have two participants whose next of kin is an underage child. They obviously have a legal next of kin who isn't, but both of these women have lower grade tumours, and their hope is that if and when their tumours proceed to grade 4 astro or GBM, their children will be of an age where they are able to give consent. So we are having those conversations with them under the age of consent to introduce the topic, and it's something that we're present in the conversations, but we really do let the parent take the lead in those conversations and try to just provide context and answers where we can without causing any form of harm. It's a really challenging area.
I can imagine. Now I'm just going to squeeze in a last question. So Albert's asking about whether you could briefly talk about how you would process a fresh whole brain sample so that it's suitable for biobanking and distribution. What are some of the steps?
Yeah, look, that's a great question. And there's papers, a wealth of literature on how this can be done, oftentimes relevant to the disease type. There are some really extensive papers out there from the Columbia Brain Bank, for example, in the US, and closer to home, Sydney has some amazing brain banks. For us in brain cancer specifically, as I said, they're snap frozen in liquid nitrogen. We're then able to take a punch or a core through the obvious foci of disease, and we use the H&Es from the adjacent formalin-fixed tissue to guide where we can punch from for those. We do have a copy of the MRI in the mortuary, so that if there are multiple foci of disease, the mortuary clinicians are able to make a decision as to what they collect. We have collected the entire organ in some cases, but based on the MRI report and based on the macroscopic dissection, they'll make a decision on what can be retrieved, and then it's frozen over here at the bank and released, as I say, with consultation to the report created from the H&Es. I hope that answers your question.
Yes, that was great, Cass. Thank you so much. Look, I think just in given the time, we've just gone past the hour, so we just want to thank you so much for sharing your time, your expertise, and also your compassion. Thank you.
Thank you for having me. I really appreciate it.
Wonderful. Thanks so much. Thanks to everybody for coming along as well. Thank you, Cass.
Thank you. Bye.